Good afternoon, and then thank you, respected chairperson, for a kind introduction. Thanks, Dr. Mohan, Dr. Ranjit, and Dr. Anjana for giving this opportunity. It's a nice flow of talks. And after metformin and after DPP-4, I'm talking about SGLT inhibitors. I mean, what is new or anything like that? It's more of a revision of whatever we can do with SGLT inhibitors. So I thought, what is it I can do? So I thought, it's a place in therapy. Why should we have SGLT inhibitor as a place in therapy? And who should be used for SGLT inhibitors in therapy? And when it should be used? So these are the three things we need to answer. So because there are so many doubts are there whether to start in the beginning or we have to start only after the complications will set in, and that we'll answer to a certain extent. Now, why? If you look into this, it's almost 2 centuries ago. It has been found from the bark of an apple tree. It has been that the glycosylphilic effects, fluorescein, that's called as, and then first one is the first compound was delivered in about 1930, but it had a lot of gastrointestinal side effects and poor oral availability. That's why it has been stopped. But you can see that in 2013 and 14, you can see that all the gliflozins, that is Cana and DAPA and empagliflozin were introduced, and then the CVOT trial with EMPAREG outcome, which has come in 2015, has really changed the way we need to treat the treatment. And then I think after getting into our market about these gliflozins, you can see that there is so much of interest that has been generated. But you see that, but you can see that in 2013 and 14, you could see that they have been approved by US FDA for management of type 2 diabetes. So they are very good anti-diabetic drugs. First of all, we need to understand they are very good anti-diabetic drugs, and use them as an anti-diabetic first. And then later on, we could find that there are so many advantages that we are able to get because of the advantages in the sense that in all systems, cardiovascular and in the liver and you name anything, in the renal, the protection and the improvement, it's an amazing molecule. This is an amazing SGLT inhibitor, is an amazing molecule. I think everyone should use it without any hesitation. Now, if you look at the effects of SGLT inhibition and metabolism in type 2 diabetes, the primary effects, we know that I don't need to explain to this audience about how it works, but what is it? It causes glycosuria, right? The blood glucose is pushes out in the urine, and then so it brings down the fasting and postprandial glycemia, and that improves the time in range, and also there is a slight risk of genital infections as well. And then if we look into the metabolic modulation, there is what is called a substrate switch. Substrate switch is nothing but reduction in adipose, because you keep on pushing the glucose out, not being utilized. So the alternative mechanisms of fuels are needed. So one thing is that the adipose tissue will be broken down to free fatty acids, and then it will be used as fuel from the liver to cause hepatic glucose output and etc. So there is a reduction. So what happens is there is a reduction in adiposity. Naturally, when free fatty acids are used, ketogenesis can happen, which is very, very mild. Don't think that it is going to cause diabetic ketosis, except in type 1 diabetics or and insulin-dependent type 2 diabetics. Improved myocardial efficiency will happen, and then it also decreases uric acid levels and also decreases the renal energy requirement, and then improves iron metabolism as well. And if we get early clinical effects, if you see that as the fat deposit, especially the ectopic fat, what we call as ectopic fat, it is more relevant for Indian population, mainly because if you could see that in the relevant, that is thin fat Indian, where waist circumference is more, the ectopic fat, which is very high in our population, so that the ectopic fat comes down, and also along with that the free fatty acid circulation comes down, indirectly the insulin sensitivity also improves. It's a cycle. So it also causes improvement in vascular dynamics, improvement in autonomic function as well. And so with all these effects, you can see that the vascular complications, both micro and macrovascular complications, come down, heart rate the heart failure events come down, and the slowing of CKD progression, and the reduction in anemia, and pneumonia, even sleep apnea, gout, and all also can be, because uric acid also comes down. So you can see that. Let us look into that, how it happens in the heart. Everything, whenever an antidiabetic drug is used, we talk about CVOT, and how it works is that it reduces the preload reduction and afterload reduction, so that the improved cardiac structure and function happens because of, you can see that there is reduction in LV hypertrophy, and then reduction in LV remodeling and fibrosis, which has been done by empagliflozin. The myocardial structure changes have been found, and this in turn will cause good cardiovascular health. Now look at the SGLT inhibitors. They can have an antioxidant effect as well. This is a very interesting thing. So the blood glucose can cause oxidation of the lipids and oxidation of the proteins. Oxidized lipids will cause endothelial damage, and then oxidized proteins can cause advanced glycated end products, and then they can be vascular damaging situation. So I think the SGLT inhibitors have got a direct action on reduction and oxidation of proteins and lipids, and also the proteins, so that the reactive oxygen species also will come down. So in that way, vascular protection has been there with SGLT inhibitor. So endothelial dysfunction, because of all these things, you can see that there is an increased nitric acid production with SGLT inhibitor, reduce inflammatory mediators, and then enhance the enhanced atherothrombotic effect, and also improved endothelial barrier function, so that the platelets doesn't break the endothelium and go into the vessel. And because of these things, you could see that SGLT inhibitors in general have got a very good anti-atherosclerotic effects. By various mechanisms, you can see that. And reducing the oxidative stress, endothelial dysfunction improves, and then foam cell formation reduced because it doesn't happen, the endothelial barrier is blocked, so that you don't get into that. So there are so many platelet aggregation and so many things that can happen. Now, it's not just what we have to think about, but we need to know whether it is gone into the clinical trials as well, actually, because we know the pathophysiological benefits of that. But one of the first things that we can have is that we have the EMPARAG outcome, and then the CANVAS trial, and as well as the DECLARE-TIMI. All the three trials have shown that there is a definitely MACE reduction is a very significantly seen in all the trials. One of the things about EMPARAG outcome trial is that the CV death is also reduced in highly vulnerable heart patients, actually. Now, why is it we talk about heart failure as well? Look at this, that nearly 1 out of 2 people will have diastolic dysfunction, almost 50% of them people will have, and then that includes in India as well as in outside the country as well. 27 echocardiography based studies have shown that about 46% of the people with type 2 diabetes have got a diastolic dysfunction, and then there can, in fact, the heart failure comes earlier than actually CAHD or CVD. So I think we need to look into that. Now, why we are talking about this 46% of the people who got LV dysfunction is that because hospitalization for heart failure is going to come down when you use SGLT inhibitors. This is apart from all the molecules in the range that we have got definitely an improvement in the hospitalization heart failure, almost 35 to 40%. So this is another important. Now, one of the reasons why we need to talk about hospitalization for heart failure is that this can be, hospitalization for heart failure itself can be a reason for cardiovascular death as well. So if we can prevent that, I think we can reduce the cardiovascular death as well. Now, look at the renoprotective effects of SGLT inhibitors. Now, what it causes? ACE inhibitors, ARBs are must for all the type 2 diabetes, especially if you got a DKD, and then you can see that the efferent arterial dilatation happens, whereas SGLT inhibitors, what it does is it causes constriction of the efferent arteriole. So that what happens? What is it we need to do that? In the glomerulus, the intraglomerular pressure comes down so that the proteinuria comes down. The damage to the kidneys also will come down. Very simple way of looking into that, very simple way of telling it, but it's not as simple as what we think. It is done by the SGLT inhibitors with combination of RAS blockade. So these are the two things which can give protection to the kidney as well. Now, if you look into that SGLT inhibitors and CKD protection, everything, in fact, you can see that all the molecules that are available, CANA, DAPA, and as well as EMPA, have been instrumental in reducing the CKD progression amongst diabetics. Now, what is most important is the latest one that has come is EMPA kidney trial, which has come in, which has told us that we can use SGLT inhibitors up to EGFR 20. So previously, when it came about 10 years ago, we used to say that if the EGFR is less than 50, don't use the drug. Not for glycemic effect. They say that because there is no glycemic effect will not be there, so don't use it. But later on, they have found it so important, and then you could see that even at EGFR 20, it can be a protective mechanism for so in general, if you see that any drug, any SGLT inhibitor, if you could see that we can postpone the progression of the disease for about 15 years, and that is not a small thing to at all. So use that drug in every situation. No doubt why KDIGO and clinical practice guidelines for evaluation and management of chronic kidney disease have suggested the first line therapy for SGLT inhibitor, but stop it when they go for dialysis. That's only thing is that. But we can use it up to 20, and there are people who have been using even when EGFR is less than 10, up to 10 they have been using, but generally it is suggested to use it up to 20. You can start the drug even at 20, and when you go for dialysis, you have to stop it. So I think this is the importance of why the SGLT inhibitors can give and protect the kidney from progressing into other disease. Now, there are so many other effects, like Dr. Ranjit was talking about the brain effects as a dementia. There seems to be some benefit in the brain, benefit in the cancer cell, and also in the bowel effects. That is the colitis severity comes down by using SGLT inhibitors. And of course, if you look into that after pioglitazone and GLP-1 receptor analogs, which can cause reduction in MASH, you could see that the other drug which does it is with SGLT inhibitors. Again, the cycle is that it reduces the free fatty acid levels, and so that you have the fatty deposition in the liver also come down, because the weight reduction also is going to be there. We know about the renal effects, but bone effects are a bit dicey. There are some contradictory effects, whether it is beneficial or not beneficial in the. Now, who should use? Now, for the simple question, every diabetic has to probably can be put on SGLT inhibitor, basically because it's a very good anti-diabetic drug. That is number one. Number two is that unless there is a contraindication, like in a type 1 diabetes or the recurrent urinary tract infections, and history of pyelonephritis, and then you can see that those people who got intolerance to that is the only people. Otherwise, in general, any type 2 diabetic is a good candidate for taking it. Now, the most important thing is that 1/3 of our patients, type 2 diabetic patients, will have established cardiovascular disease. 1/3. And if you investigate them, other 1/3 will have subclinical cardiovascular disease. That means about 2/3 of our population with diabetes have got some amount of cardiovascular disease. And then with all the cardiovascular benefits that we have with SGLT inhibitors, is a right candidate for using most of our patients. Now, even the WHO says, and even our Minister of Health and Family Welfare says that the target is to reduce in the NCDs, reduce the cardiovascular deaths that happen. And that probably can be possible with SGLT inhibitors as well as GLP-1 receptor analogs. Now, looking into that, I think the Dr. Srinivas Murthy also showed about this, about the Indian phenotype characteristics. We tend to have earlier onset of diabetes, a long duration of diabetes, lower BMI, and higher waist circumference, lower HDL, but relatively high triglyceride and HbA1c when compared to white Europeans. Now, if you look into that, SGLT inhibitors will bring down the triglycerides and improve the HDL as well. So that is another thing. And then look at the percentage of fat that can happen. We are metabolically obese. Compared to whites and other ethnic groups, Asian Indians have a great amount of intra-abdominal fat and thicker truncal skin folds, which are very, very insulin resistant. That's what we need to do. And then Indians are also known to the beta cell dysfunction happening is also quite faster, and SGLT inhibitors can be used independent of insulin, independent of beta cell function. So this is another point why we need to think about SGLT inhibitors, we can use it. So at any stage of the disease, early stage, mid stage, and insulin requiring stage, at any stage these drugs are going to be very useful. So our patients are metabolically obese, so that anything that can help in reducing the waist circumference, anything that can reduce the ectopic fat is going to be a great benefit in insulin resistance, in cardiovascular disease, and even otherwise even the chronic kidney disease as well. Now, this is another interesting finding that in Indians what we have is that according to the lipid guidelines, the Lipid Association of India criteria, the newly diagnosed Indian type 2 diabetic patients have got a high ASCVD risk. Not everybody has got high risk, but here is. So what we could see that there are almost 80% of our people are having either one or other risk factor that has been explained by Lipid Association of India, and then that also promotes that we need to have a SGLT inhibitor on board for our treatment. Now, look at the NAFLD or MASH, what we call. We can see that Dr. Ranjit was also speaking about MASH in that. You could see that India has got the global incidence of MASH is about 25%, whereas in India it is 38%. So this is another point what I need to think about, so that we can think about SGLT inhibitors into that. And that is the reason, if you can see that MASLD, one of the drugs that have been given for choice is going to be the SGLT inhibitors. Apart from pioglitazone is the best for MASH. Next is GLP receptor analog, and next is SGLT inhibitor. Now look at this. This is the most important cartoon, I feel. We can see that this cartoon, if you can see that, because of the fat redistribution, you could see that the waist circumference comes down, the fat deposition in the liver comes down, pericardial fat comes down with SGLT inhibitor. What else you want? And of course, you could see that proper biological mechanisms, you got a better mitochondrial biogenesis and also renal protection as well. All the target organs have been protected by SGLT inhibitors. When should we use it? As soon as possible, or the first time when the patient comes, if they're not on SGLT inhibitors, you use it, even from the beginning that we can use it. Why? Because they are very, very effective drugs. Don't delay the diabetes control, because even 1 year of uncontrolled diabetes can cause increase in MI, stroke, heart failure, and CV death. And look at this. It's a very important thing actually. This is the time in range with empagliflozin, the study which has been done, it clearly shows that by the day 1, that is you give today, tomorrow the TAR improves. So every 10% improvement in TAR will be reflected as reduction in HbA1c by 0.8%. So this is the most important aspect. The improvement in the TAR is a very important thing. Of course, sustainability. That is more than 4 years we can ensure that the HbA1c will be reduced, and then this is across the gliflozins, not only DAPA, but EMPA and CANA as well. And then in any combination, you can see that there is a reduction in HbA1c. And then I think SGLT2 inhibitor is a first-line anti-hyperglycemic in the management of type 2 diabetes in the context of Indian phenotype. A systemic review and consumption, I'm also one of the authors for this paper. So friends, let me say that we need a holistic approach to cardio-renal metabolic. This is now catchword, CRM or CKM. Cardio-renal metabolic care in early. You can see that, we can see that essential treatment for risk factor control is lipid management, glycemic control, blood pressure reduction, weight management. Essential treatment for organ protection, SGLT inhibitor will become in first into that, apart from GLP-1 receptor analogs. So early coordinated treatment is crucial to improve patient outcomes and improve the quality of life. Thank you for patient hearing.